Welcome, everyone. Thank you for joining us. Our webinar today is entitled Parasitology Stool Diagnostics, From Basics to Blastocystis. Our speaker is Dr. Christine Stubbe. My name is Dr. Lenore Powell. I am a medical education specialist in Genova's Atlanta branch, and I will serve today as your moderator. We would like to welcome Dr. Christine Stubbe. Christine Stubbe received her doctorate of naturopathic medicine from Bastyr University in Kenmore, Washington. She completed a 3-year family practice oncology residency at Yellowstone Naturopathic Clinic and Frontier Cancer Center in Billings, Montana. Dr. Stubbe joined the medical education team at Genova Diagnostics to help provide education support to practitioners. Please remember, you will have access to the presentation and the slide deck on our website within a few days after the webinar. You can access these resources, previous webinar recordings, brief video modules, and other materials by clicking the Clinicians tab on the home page. I am going to turn over the role of presenter to Dr. Christine Stubbe.
Great, thank you, Lenore. All right, well, thanks for being here today, everybody. I'm really excited to talk to you about parasitology. I just think that the world of microorganisms is so fascinating, and I'm excited to share with you what I've learned about parasitology. So we're going to learn about the most common parasites, risk factors for those parasites, and clinical presentation. We're going to talk about what type of testing we're doing here at Genova, including PCR detection. We're going to learn about an organism called Blastocystis and the subtyping, and then we're going to go through 2 case studies at the end. So the first thing I want to do is define what is a pathogen and what is a parasite. They both kind of sound a little bit similar. They both start with P. They're both 8 letters. So I think sometimes people get that confused. So we're going to make that distinction here. So the basic definition of a pathogen is that it's a microorganism that causes or can cause disease. And so some pathogenic agents include parasites, which we're going to be talking about today, bacteria, yeast, and viruses. And this is a controversial subject. There's this ongoing debate about what constitutes a pathogen, and it really depends on the organism virulence factors and the host health status. So what's the status of the patient's immune system? What is a parasite? So the Centers for Disease Control defines this as an organism that lives on or in a host organism and gets its food from or at the expense of its host. So are all parasites pathogens? No, not necessarily. Not all parasites cause disease. And I think that might be a common misconception too, is that anytime someone hears the word parasite, they get a little freaked out and think that it's a huge problem. So most parasites are pathogenic, but not all of them. Are all parasites found in the intestines? No, there are many, many parasites that are found in the intestines, and we'll look at a few of those today, but some are found on the skin, so lice, in the blood, the parasite that causes malaria. And there's 3 types of parasites that cause disease in humans. So protozoa, and this is a picture here under the microscope of a protozoan organism, helminths or worms, which are usually visible to the naked eye, and ectoparasites, which are outside or on the skin, so lice, bed bugs, things like that. We're not going to talk about those today because they're not intestinal. So this is a list of parasites off to the right here, and we have that up on our website if you wanted to refer to it. These are all the parasites that Genova detects on a microscopic ovum parasite exam. And what we can see are protozoa, which are single-celled organisms, so they're very, very tiny, and we see them under the microscope. And helminths are multicellular organisms that can be seen with the naked eye. And what we see under the microscope are the eggs or ova of the worms. So a question that you have to ask when you see a patient is, what is the pretest probability that they have a parasite? Each parasitic infection is really its own disease, and there are many, many parasitic diseases, as you saw on the previous slide with that whole list of organisms, and each one might come with its own set of risks and its own set of symptoms. So you kind of have to know what organism you suspect in the patient. So some of the main risk factors for a parasitic infection would include patient living conditions and hygiene, so particularly people who live in really crowded, unsanitary conditions. A lot of parasites are picked up in schools. Drinking water is a way to transmit parasites, and lack of hand washing. You also have to think about the region of the world. So Genova is an international company, and the majority of our tests come from the US and the UK. You have to think too about travel history. So did the patient recently travel to an endemic area that had a certain parasite or parasites? You have to consider also outbreaks that mainly occur through food as well as water. Some cultures use feces as fertilizer, which it can make great fertilizer, but you want to make sure it's free of parasites. You want to think about the immune status of the patient. So if they're immunocompromised, they might be more at risk for picking up any infection. And the age of the patient matters. That pertains to the immune system, so especially the infants or elderly. Child care workers and children are more at risk. Exposure to animals, consumption of raw or undercooked pork, beef, and seafood. And then certain groups like backpackers, hikers, campers, swimmers drinking untreated water. And it can also be passed through exposure to feces through sexual contact. So as I said, each parasite is its own disease, each parasitic infection, and some have unique symptoms like anemia with hookworms or neurological symptoms with tapeworm. So you wouldn't necessarily expect those things with other parasites. Off to the right side of the screen here, we have the parasitic organism chart that you can find on our website. So you can check this out to see the symptoms of each parasite. But in general, a lot of the symptom pictures overlap, and you'd see things like diarrhea, abdominal pain or discomfort, bloating, nausea, vomiting, anal itching, loss of appetite. Some of them may be asymptomatic. So some take-home points: the pretest probability of having a parasite will vary from patient to patient due to their risk factors. And Genova is an international lab. We receive samples mainly from developed countries. Therefore, the pretest probability of having a parasite is lower as compared to if we were doing this testing in a developed or developing country. In developed countries, protozoan parasites tend to be more common than helminths, but they're not prevalent because there are adequate public sanitation standards. And in developing countries, both intestinal helminths or worms and protozoan parasites are prevalent. So how do you detect a parasite? How would you know the patient has a parasite? We're going to go through these different testing methodologies that we use here at Genova. So microscopic O&P or ova and parasite testing is the gold standard, and currently the only methodology capable of detecting any and all stool parasites. It's ideal for finding any parasite, so basically we're looking under the microscope, whatever's there, we see it and we report it out. We can also see other things as well, including white blood cells, Charcot-Leyden crystals, which are eosinophil breakdown products, and they are present in patients with tissue invading parasites or allergic conditions. Some limitations to ova and parasitology, the microscopic exam, is that sometimes it's difficult to visualize very small organisms that can be obscured. Different organisms shed ova at different times, so there's increased sensitivity when you sample the patient on multiple days versus just one day. And then the training of the technician. So I hesitate to put that as a limitation for Genova because our technicians are highly trained. We've been a laboratory for over 30 years, and some of our techs have been with us for more than 20 years. We continue to receive exceptional scores on proficiency testing like CAP testing and WSLH testing. So I have a lot of confidence in our technicians, so I wouldn't necessarily say that that's a limitation for Genova. So when we receive the sample in the lab, the sample is centrifuged and then slides are prepared. So we add different stains so we're able to see particular organisms that can be seen better with that stain. And then we look at the slides under high-powered fields. So again, we're looking for microscopic parasites, which are the protozoa. We're looking for the ova of worms, red blood cells, white blood cells, anything that we see under the scope, we're going to report out. And this is what our report looks like over to the right. So if an organism is seen, it'll be reported as the amount seen, so rare, few, moderate, or many, and then any additional findings will be at the bottom of the page. We also do a macroscopic for worms test. This is available as an add-on to some of our tests. Worms are primarily diagnosed by ova in the stool, so it would be seen during the microscopic O&P exam. The macroscopic add-on test is appropriate when patients see a worm in their stool. What we prefer they do is that they pull that worm out of the stool, make sure it's in the green top container that's in the kit, and it's preferred that they write worm on the container because in some of the kits there are 3 green top containers and we want to make sure we're looking specifically at what the patient is directing us to look at. The macroscopic exam for worms must be marked on the requisition form, and this is important because the lab needs to be alerted to look for the worm. Otherwise, it's going to be spun down for the microscopic exam, and as you can imagine, if you spin something that fast, it can rip the sample into pieces and parts. So before they spin it down for the microscopic exam, they're going to perform a gross examination on the specimen, looking for the macroscopic evidence of worms. A lot of the time it's mucus or food like a bean sprout that can look like a worm, but we do find worms. A question that we get sometimes is about pinworm testing and the best way to test for that. So there's some references at the bottom of the slide with different techniques. And while pinworm eggs can be seen in a stool sample for the O&P microscopic exam, there's often a low yield. So the best way to diagnose is the classic tape test, where the eggs stick to the tape and the tape can be placed on a glass slide and viewed microscopically. This can be sent in to Genova. We don't provide the slides, that can be obtained from the clinician, but Genova can analyze the slides sent in as a direct para evaluation. Another methodology we use is EIA, or enzyme immunoassay, which is detecting a specific organism's antigen. So basically a protein of an organism that's defining or unique to that organism. It's ideal for possibly increasing the sensitivity of detecting some organisms. There are FDA cleared assays available. Limitations would include you're really limited to the individual organism being targeted. There may be a higher false positive rate. And there's only commercial products available for 3 parasites. And we look at those 3, the Cryptosporidium, Giardia lamblia, and Entamoeba histolytica. So this is how it would look on a report. It would either be reported as negative in range or positive out of range. And the diamond there shows that we use the FDA cleared kit. So another methodology that we just introduced to our GIFX product is PCR, or polymerase chain reaction, which is a technology that's been around for quite some time, and it detects a specific organism's DNA. So we use real-time PCR, or qPCR, for 6 organisms, and we'll see that in a minute. And we use next-generation DNA sequencing for the Blastocystis subtypes. This is ideal for organisms that shed ova irregularly, or parasites that may show up irregularly. And it can increase the sensitivity of detecting some organisms. Limitations would include it's limited to the individual organism being targeted, similar to that EIA that I just showed you. And there's a limited number of FDA cleared targets. There are currently 4. So basically, to match the comprehensiveness of ova and parasitology microscopy, you would need a PCR primer or probe for every organism in order to have a comprehensive test that matches the O&P exam. And so we saw that huge list of organisms back at the beginning. You would need a probe for every single organism for PCR. I want to talk about the difference between laboratory developed tests and commercially available testing with FDA cleared status. So Genova created the laboratory developed tests to match the FDA cleared status by comparing our PCR assay to the gold standard O&P samples that we receive in our lab, or the FDA cleared EIA tests. So if you have nothing to compare the laboratory developed tests to, like a gold standard, then the primers can be questionable. So you want to make sure that they've been validated and that it's actually capable of identifying the correct organism. So at this time, the 4 commercially available tests that do have FDA cleared status are Cryptosporidium, Cyclospora cyatinensis, Entamoeba histolytica, and Giardia lamblia. Excuse me. So PCR amplification, it's a big topic to try to break down and make it high level. And I'd encourage you to go on YouTube and watch videos of this happening. It's pretty cool. There's a lot of animated videos. But basically, the parasite DNA is isolated from the stool sample, and then the strand of DNA is separated, and you can see that happening over at the top left of the picture here. And a fluorescent primer matches up to each of the 2 strands, and so now you have 2 copies. Each of the 2 copies separate, and this process repeats over and over and over for 40 cycles. So you're millions and millions of copies, and basically, if the DNA of that organism was present in the patient's stool sample, it's going to light up or fluoresce. That's what the fluorescent primer is matching up to. And so basically 2 conditions must be met in order to see a positive PCR result on testing. 1, the DNA of the organism is actually in the stool sample, and 2, the lab has a PCR primer that matches that specific organism. A question that we've gotten is, can PCR be too sensitive, resulting in overdiagnosis? And it can be if you increase the number of amplification cycles. That can lead to a false positive due to actually picking up artifact and not the organism's DNA. And so we don't increase our number of amplification cycles There are standards for PCR usage. Genova is certified by ATCC standards. So basically, we don't want to end up treating something that's not really there. And this chart off to the right kind of illustrates that. So this is not a Genova specific chart. I just put it here because I like visuals and it helps me to understand it better. And so the more you amplify, the more amplification cycles there are. At the top here, you can see that the percent of positive samples reaches, 100%. So this is what our parasitology results page looks like. The results are reported as detected or not detected. And the 6 that we chose were Blastocystis, Cryptosporidium, Cyclospora cyatinensis, Dientamoeba fragilis, Entamoeba histolytica, and Giardia. And these were chosen because they're common. In some instances, you can see a PCR positive result and O&P negative, or a PCR negative and O&P positive. Excuse me. And basically, one thing to understand when it comes to discrepancies is that these samples are being collected in different tubes and possibly on different days. So with ova and parasitology, you can do a 3-day collection, whereas the PCR tube is just collected on that 3rd day. So that's one explanation for possibly seeing discrepancy, is that you have completely different tubes that you're using. Another possibility is when the patient's actually collecting their sample that's in the little container, they're scooping from different parts of the sample. And we have to remember that stool is not homogeneous. And so it's possible that, especially if there's a smaller amount of the organism present, that it's not homogeneously distributed all throughout the stool sample. So if you scoop from one side and then into one tube and scoop from the other side into another tube, it's possible that that could be an explanation for the discrepancy as well. For PCR positive and O&P negative, it's possible that there's irregular shedding. It's also possible that there were non-viable parasite DNA passing through, so you always want to correlate clinically with those findings. In the event of PCR negative, so the DNA wasn't detected, but O&P positive, we actually saw the organism. This is a phenomenon that has been documented in peer review literature and studies supporting FDA approval, where 15% of samples submitted for PCR demonstrate inhibition. And so the question is, what's causing this inhibition of the PCR reaction? It could be due to many factors, and we don't completely understand all of them yet, but medications, excessive unrelated DNA, there's a lot of potential interference. So the question then becomes, is one method better than the other or more sensitive comparatively? And the answer is no, one's not better than the other, but both together we've found results in an increased sensitivity. And so having this multi-pronged approach results in a comprehensive, highly sensitive, and highly specific assessment of parasite infection. So we offer a complete assessment for parasites on these stool tests. The GI effects profile, so the 2200, 2205, and 2207, all have O&P microscopy, and they have the new PCR targets that we added on. If you go with the CDSA 2.0 or CDSA with parasitology, they both have O&P microscopy as well, and we use EIA for those 3 parasites. So currently, the only methodology capable of detecting any and all stool parasites remains the gold standard microscopic O&P exam. And a combination of methodologies is really the ideal approach to cover the breadth of organism detection. So using a combination results in a higher rate of positives. The introduction of PCR parasite panels does not eliminate the need for O&P microscopy. There are no commercially available tests at this time that are a complete replacement for O&P microscopy. So again, you remember that long list of organisms that are identified under the microscope. There's not a test available yet to match that. Genova is going to continue to offer O&P microscopy, PCR, and EIA testing for parasites. So let's talk about Blastocystis. This is a really important bug. It's the most common protozoan parasite that we see here at Genova. And we are the first company to offer subtyping for Blastocystis. And the literature is moving away from calling it hominis. So a lot of people are familiar with Blastocystis hominis. They're now referring to it more as species, SPP. Hominis refers to human, and humans can be infected with genotypes from other animals as well. It's a very common parasite. It affects up to 30% of people in industrialized countries and up to 76% in developing countries. It's spread via the fecal-oral route. It can live in the intestines for years. And pathogenicity is controversial. So genomes of 3 of the subtypes have been sequenced so far to try and understand pathogenicity. It lives in the ileum and cecum, and it's adherent to the outer layer of mucus and thrives in an anaerobic environment and in the presence of bacteria. So it's eating bacteria as its food source. It's associated with higher microbial diversity and richness in some studies and might be regarded as a commensal organism, but other studies regard it as an indicator of dysbiosis. So there's still some conflict in the literature about whether it's beneficial to have it or not. In one large-scale metagenomic analysis, the organism Methanobrevibacter smithii was strongly associated with the presence of Blastocystis, and that's an organism that we measure here at Genova as well on our GIFX commensal bacteria page, and we saw the same thing. So what we've been doing is looking at these organisms against our biomarkers and looking for any sort of patterns or trends. And so Blastocystis positive samples do have a unique biomarker and microbiome profile on the GIFX 2200. And what we found is that if only one methodology is positive for Blastocystis, so either PCR or O&P, that connection is much weaker. So Blastocystis being positive in both PCR and O&P, we tended to see that unique biomarker composition. And the reason is the level of Blastocystis is the main driving force for those biomarker associations. So if there were many seen under the microscope versus a few amount or a rare amount, then that correlation was stronger. And the biomarker pattern that we saw was that there were significantly lower fecal inflammation markers, including calprotectin, eosinophil protein X, and secretory IgA. And so a lot of people would think, oh, wow, that's a great thing to have low inflammation. So we don't know the significance of that yet. And yes, it is great to have low inflammation, but what about not being able to mount an immune response? So we can't definitively say that at this time, but it's kind of like the chicken or the egg conundrum. Is the immune system not able to respond, therefore Blastocystis is able to thrive, or did the presence of Blastocystis result in a lower inflammatory picture? So we don't know that yet. And as I mentioned, we also saw that correlation with Methanobrevibacter smithii, and we saw some other biomarker patterns as well. Here's a list of symptoms of Blastocystis, and a lot of that overlaps with the general symptoms that I mentioned earlier for parasitic infections. So a lot of GI symptoms, abdominal pain, diarrhea, constipation, but then there are symptoms like fatigue and joint pain and urticaria, and a lot of patients can be asymptomatic as well. So it has a wide variety of symptoms. So I mentioned we are subtyping Blastocystis, and the subtypes are thought to be associated with different symptoms or clinical outcomes, although the literature is not yet clear. The idea of the subtypes in the literature is well established, but more research is needed for definitive answers regarding the clinical significance of each subtype. So we're excited to be offering this and to be following these markers and to see what the correlations are. We're going to continue to gather data and provide more information over time. And one of the reasons why the literature might be mixed is because of different methodologies being used for studying those subtypes. So we're going to provide data from our assay. And we're looking both at the other biomarkers on the GI effects as well as the surveys that patients submit. And so the more surveys we gather, the more data we have. So I'm just putting in a plug here for patients, if you're listening, to make sure you fill out those surveys, and for clinicians to encourage their patients to do so. On the left side here, you'll see some information from the literature on subtypes, and then on the right, a comparison of what we've found so far. And so there are 17 subtypes, and the subtypes found in humans are subtypes 1 through 9. They're transmitted by different animals, which is called zoonotic transmission. They're found in different geographic regions. And per the literature, subtypes 1 through 4 make up 90% of the findings, with subtype 3 being the most common. And it is possible to have more than one subtype. So at Genova, so far, about 82% were subtypes 1 through 4, which is similar to what the literature was showing. And we also showed subtype 3 as the most common, but at 29%. And we have reported patient samples with mixed subtypes so far. This is a chart that can be found in the stool support guide on our website. And it's just kind of outlining the geographic distribution of each subtype, animal transmission, and associated symptoms and conditions. And so this is per the literature. We're really, again, excited about getting more patient surveys back to associate symptoms and conditions. This is a diagram from the paper that's referenced at the bottom of the page showing that, excuse me, different subtypes have different mechanisms, which may result in the different pathogenicity and symptoms that we might see with the individual subtypes. Excuse me. So a lot of people ask questions about treating the subtypes. And at this point, the literature is mixed and it's preclinical. Large-scale clinical outcome studies are lacking. Excuse me, I'm going to drink some water here. So hopefully we'll be able to correlate that patient data as the literature evolves. And in the meantime, clinicians can treat a symptomatic patient regardless of subtype until more information is available. And the treatments that are currently being recommended by the CDC and other organizations are not to treat an asymptomatic patient. If they're symptomatic, it can be self-limited, which wouldn't require treatment, or metronidazole has been the top recommendation for a long time, but there's issues around resistance there. So TMPSMX or trimethoprim, sulfomethoxazole, iodoquinol, or nitazoxanide are being recommended as well. It can be difficult to eradicate, and so triple antibiotic therapy is being explored versus using just one agent. And certain subtypes may be more resistant to treatment. A lot of clinicians are interested in natural treatments, and there aren't a lot of studies using natural treatments for blastocystis, but there was one study on children where Saccharomyces boulardii, which is a beneficial yeast, had favorable cure rates, and that was compared to metronidazole. A high fiber and lactose-free diet can improve symptoms. Botanicals such as coptis, garlic can have inhibitory activity. And then there was a small human study where 8 out of 11 patients had eradication with oregano oil and symptom improvement in 7 out of 11 symptomatic patients. This chart is also in that stool support guide that I mentioned, and it's basically pulling from the literature in vitro sensitivities for each of the subtypes. And so if it's sensitive, that means it would potentially be effective against blastocystis. Anything in the resistant column probably wouldn't be effective. So there's a caveat here about in vitro and not tested in the human body yet. That's always something to be careful about. So that's what I mean by this is preclinical. We wanted to provide the information for you, but you have to kind of be careful about your treatment strategy when you base it on in vitro. This other chart here is showing the few human studies that are out there on treating blastocystis subtypes. And this is just, half a page. The rest of the chart is in that stool support guide. And so a lot of these were case studies, just looking at one person, or very, very small studies with 10 or 11 people. So the caveat here is it's a small amount of people. We would love to see larger studies with more people to get better data. Let's look at a couple of case studies. The first one here is a 26-year-old male, and he had an acute onset of diarrhea, and now it's been chronic for 4 months. He hadn't traveled recently. He does do a work trade at a farm twice a month. He thinks he may have eaten out at a restaurant at onset, so the clinician ordered the GIFX gut pathogen profile, which is the 2207, and here are his results. So at the top of the page, you can see that blastocystis was found, and under the bacteriology pillar, there are potentially pathogenic bacteria. So those factors may be an explanation for his diarrhea. Under PCR here, we detected the PCR, and it was subtype 1. So from the support guide, we see the subtype chart, and we see that it can be transmitted by pigs, monkeys, cattle, birds, rodents, dogs. Some of those may be found on a farm. And the associated symptoms were that it's seen in GI symptomatic patients. It's possibly the most virulent subtype. This is his O&P microscopic results page, and we can see blastocystis was detected. There were a few detected. And he does have these potential pathogens, pathogenic bacteria, the Citrobacter brachii and the Enterobacter cloacae here at 4+, both capable of causing diarrhea. The patient was averse to conventional treatments and antibiotics and requested natural treatments. So the clinician was trying to get the biggest bang for the buck. Can I give them something that'll kind of target all the organisms? And they selected a commercial formula that contains garlic, Coptis chinensis, and oregano. And so when you look over to the right here, the bacterial sensitivities, the way the page works here with the natural agents is that this gray shaded bar, as long as it reaches the halfway point, it's considered an effective agent. And so technically for both organisms, the Citrobacter brachii, the Enterobacter cloacae at the bottom of the page, all 4 natural agents would work. The farther to the right the gray bar goes, the better or more effective the agent is. And so with the clinician selecting a formula that has oregano, that addresses the Citrobacter here and the Enterobacter. And remember the slide that I had on natural treatment for Blastocystis, it was effective in a small patient study there as well. And garlic and Coptis chinensis were also effective in vitro. And then the clinician also chose a probiotic formula with Saccharomyces boulardii. So remember that study on Blastocystis and Saccharomyces. And then Lactobacillus and Bifidobacterium were chosen because their beneficial bacteria levels were low on the stool exam. And on follow-up, the symptoms had resolved. And this is a snapshot here of that in vitro treatment chart for Blastocystis. And you can see for subtype 1, garlic was effective. So essentially that was hopefully helpful in the treatment for the Blastocystis. In the second case, we have a 66-year-old male with significant arthritis and pain. And he'd already been through several rounds of metronidazole treatment for Blastocystis, and each time noticed an improvement in his joint pain, and then over time it would come back, and the clinician would retest, and he'd either still have positive or have a new positive Blastocystis test. That's tricky. So is this a resistant case of Blastocystis, meaning it's resistant to the metronidazole? Or is he effectively being treated and just being reinfected between treatments? It's hard to say, and it's really important to look at the patient's risk factors, you know, hygiene and living conditions and working conditions and the population he might work with to see if maybe he is being reinfected and needs to do something differently. So the clinician ordered a GIFX, and these are his results. We see there's Blastocystis again, and he had a couple other findings which I'm not going to go into great detail about today. If you're interested in learning about the GIFX comprehensive, there is a module on our website where you can learn more about test interpretation. And then of course we have our support guide as well. This is his O&P microscopic exam where we see many Blastocystis were detected. And then this other organism here, Entamoeba coli, it says few T/C detected. T/C means trophozoites or cysts, which is the morphological form of that organism. Entamoeba coli didn't show up on that front page highlighting the pertinent findings from his test because it's considered a non-pathogenic parasite. But one thing that I do think about when I see more than one protozoan showing up is I do think, okay, where's this coming from? Just kind of trying to figure out from his environment, you know, is hygiene an issue? Does that need to be addressed? These are his PCR results. So we see that he had subtype 8. And not a lot is known about subtype 8. So this is his commensal bacteria page. And remember that Methanobrevibacter connection, you can see close to the bottom of the page here that his Methanobrevibacter level was high. So is that possibly playing a role as well? And these are his other biomarkers. We saw an elevated level of fecal fat, but for the most part, it's a pretty unremarkable page here. One thing though with the fecal fats that I think about, I just think about the absorption of fat and inflammation. And so there are pro-inflammatory fats and anti-inflammatory fats. And so we want to make sure he can absorb his fat so he can take things that are anti-inflammatory or eat more anti-inflammatory fats like cold water fish and fish oil. This is his culture, his bacteria culture page, and not a whole lot was going on here as far as there weren't any potential pathogens or pathogens that grew out. His beneficial bacteria could be a little bit better, no growth lactobacillus, and then his bifidobacterium was at 2+. That could be a little bit better. So not a lot is known about subtype 8 as far as treatment goes. This snapshot from the support guide from the in vitro Blastocystis treatment chart is showing that there were a few studies that looked at TMPSMX or trimethoprim sulfamethoxazole as being the most effective in vitro, and metronidazole being effective at high concentrations but not total clearance. So this patient was treated with multiple rounds of metronidazole. Could that have been the issue? It's hard to say. So the TMPSMX was chosen since metronidazole had potentially failed previously. And independent of subtype, not just subtype 8, but independent of subtype, TMPSMX is suggested by the CDC as a possible treatment. He doesn't travel for his job, but he does work with people who have traveled, so potentially that could be a risk factor for him. So you want to try to look at his risk factors. For more information on treatment for organisms, you can check out the CDC, and I put a snapshot of this page here for roundworm treatment. They're pretty specific with the dosages. You can look at the Sanford Guide to Antimicrobial Therapy for information on natural treatments. Organizations like Institute for Functional Medicine or A4M can provide that education. If you're looking at supplements, Emerson Ecologics, Natural Partners, or any companies like that have consultants to answer supplement questions. And you can always schedule a medical education consultation where we'll go through the patient's test results with you and talk about general possible treatments. A question that we're often asked is, does Genova offer sensitivities for parasites? So it's kind of nice to have that culture and sensitivity for the bacteria and yeast. So for any bacteria and yeast that grow out and are pathogenic or potentially pathogenic, we automatically perform sensitivities to pharmaceutical and natural agents. And we can't do that for parasites because they arrive preserved. So the vials contain preservatives and we can't grow out a dead organism. The PCR test is looking for DNA, so we wouldn't be able to test for sensitivities there anyway. It's not really standard for labs to perform sensitivities on parasites. These are some resources for learning more about parasites in general. So the CDC has a page on every parasite. You can also check out some PubMed articles. The World Health Organization is great looking at maps and endemic areas for certain parasites. And on our website, we have a parasitic organism chart that I've showed you a couple pictures of, as well as some snapshots of charts that are in our GIFX or the stool support guide. And I'm ready for any questions that may have come in, Lenore.
Thank you so much. That was such a great presentation. We did receive quite a few clinical questions, but before we begin the Q&A period, there's three things I just want to remind the audience of. The support guide and the parasitic organism chart that Dr. Stubbe was referring to is located on the GDX website. If you go to the GIFX stool profile landing page, as well as the other stool profile pages, you will see an option for additional information, and that's where you can access those materials. The next thing I'd like to let the audience know is the modules for the GIFX stool profile interpretation that Dr. Stubbe mentioned is also found on the GDX website under either education modules or Learn GDX. And as Dr. Stubbe mentioned, you can also schedule a medical education consult that is complimentary by either calling CS, or you can arrange an appointment online. And lastly, for the audience, before we get to the Q&A section, you can download the slides or the handouts, which will be under the Handouts tab. Just click the link and the download process will begin. So let's start with this question here. Should the patient take something to flush out or purge the parasites before collecting the stool sample?
That's a good question. Genova actually did an analysis of samples that had been sent in via the purge testing and compared it to non-purge parasitology testing, and we didn't see an increase or a difference. And so we're not necessarily recommending that. I know a lot of clinicians prefer to do it that way, but we didn't necessarily see that there was an increase in detection of parasites by doing a purge.
If the clinician decides to do a purge, is there any risk of that laxative agent for the purge to impact the other results on the stool profile?
Also a great question. So especially if they're running like the GIFX comprehensive, stool transit time can affect some of the biomarkers like fecal fat. So if things are moving through so quickly with a laxative and there's not enough time for fat to be absorbed, the fecal fats might be elevated on the stool exam. And so the collection pack instructions for the tests are pretty specific about avoiding laxatives prior to taking the test. And so that is the risk that you run if you do that purge test.
When would a patient consider doing a 1-day versus a 3-day stool test?
So as I mentioned, the 3-day is going to be more sensitive for being able to pick up organisms. And so if you had an organism that sheds irregularly, you might miss it if you do 1 day, and it would be better to do a 3-day. So I always think about if the clinician suspects a parasite, to do the 3-day. They're doing the test already as it is, so you might as well have them do the 3-day, but a lot of parasites are also picked up on just a 1-day as well. So I would say that it really goes with the clinician's index of suspicion that the patient has a parasite.
What if the patient calls from home, they have a worm in their stool sample, or they found a worm in their stool, but they don't have a kit, nor does the clinician's office have a kit? What can be done in those types of cases?
Yeah, so if the clinician did have a GI kit, the green top tube is the preferred tube to put the worm in. So if the patient could just bring the worm to the doctor's office or get the green top tube. If there is no green top tube, then they can just find a clean jar in their home, and if they have some rubbing alcohol, they can put that in the jar and send that directly to Genova, and that is it's called a direct para exam. So they'd probably want to do that through their doctor's office, and the doctor's office can call client services to talk about the steps that would need to happen for sending that sample in.
What is the approximate follow-up time frame after the treatment of a parasite to do another stool profile?
So our collection instructions talk about avoiding antimicrobials for 2 to 4 weeks prior to testing. So if the organism is being treated and you want to follow the collection pack instructions, then you'd wait 2 to 4 weeks. Perhaps someone might be very eager and want to know sooner that the parasite has been eradicated or is gone. Usually you can tell by symptoms that it's gone. You could test sooner, but the reason for the 2 to 4 week time frame is that anytime we take an antimicrobial, it can interfere with the microbiome. And so if you want to give the microbiome a chance to restabilize, then that's why that 2 to 4 week recommendation is there.
What profile would you recommend to retest a patient after treatment, just to basically ensure that we have eradicated that parasite?
We have a test, it's fairly new, called the gut pathogen panel, and it's the GIFX 2207. And so that's really just looking at it's exactly what it sounds like, gut pathogens. So it's looking for pathogenic bacteria, yeast, parasites.
Well, in the interest of time, we will end our question and answer period there. So again, for additional educational materials, we would like to encourage all of our participants and audience to visit our website, www.gdx.net, and or contact client services. We also offer complimentary appointments with our medical education specialist to answer questions related to our testing, including choosing the right test and reviewing patient test results. Finally, we'd like to encourage you to register for our upcoming webinars on www.gdx.net. Next month, we will have Dr. Michael Chapman speaking on Genova's innovative methylation panel, and several dynamic speakers and topics to follow in the upcoming months. Again, Dr. Stubbe, thank you so much. That was a great presentation.
Thank you.